Hi, everyone, and welcome back to another episode of Public Health Career Conversations. I'm very pleased to have with me today a colleague, Assistant Professor Pieter de Jager. Pieter is a public health medicine specialist trained in South Africa, now working as a cardiac anesthesiologist at the Dalhousie University in Canada. And we just want to thank Pieter for his time today. I know time zones also are a bit of a difficulty to navigate. So thank you, Pieter, for taking the time out to have this conversation with us today.
You're welcome, and thank you very much for inviting me. It's always an honor to speak with my public health physician colleagues. So thank you.
Thanks, Pieter. So I'm not going to give too much away about your bio, but I just want to say that you have had a very interesting journey, and there was a very specific reason why I reached out to you is because you had started in clinical medicine, went into public health, and then a transition back into clinical medicine. And I think for the colleagues that are grappling with, these sort of transitions or these decisions, it would be useful to have an idea from you, what informed your decision. So let's start from your public health journey. What was it in the beginning that really sparked your interest in public health and made you decide to pursue public health as a specialization?
Okay, so first off, there's a cardiac surgeon here, and we went on a little boat cruise. He's got a little boat, a little yacht. In any case, and I had a long conversation with him about life decisions and how he ended up in Halifax because he trained, in Harvard and what have you. And he said something to me that I thought was really interesting. He said, life is a series of uninformed decisions. And, we try and make decisions based on the information we have during our life. And, it's impossible for us to know what the outcome of those decisions are. So we basically operate in a world of uncertainty, which, as public health physicians, we become very acutely aware of. But in any case, that being said, so I did my internship at Curtis and Red Cross Children's Hospital. And I did some medical officer time then at Red Cross. And during my medical officer time, it was that period when there was a big measles outbreak in Cape Town. And most of my time I basically spent in the emergency room resuscitating, kids with measles and, malnutrition and gastroenteritis. And, it was very exhausting work. And I often had patients who, you'd stabilize, they'd leave, and then they'd come back a week later with exactly the same problem. And some of them would die, and that would have, devastating emotional consequences for myself, my colleagues. And, I really became, for lack of a better word, upset by this situation. And there was a Professor Louis Reynolds was there. So he's a pediatrician, and he's quite the activist. And he's good friends with Professor Leslie London. And I started chatting with him, sort of just about the world, really. And he gave me a book to read. It's called The Heart of Darkness by Joseph Conrad. And this book is really about the Congo and about colonialization and sort of the brutality of that and what effects and consequences that has just on people. And that actually ignited, that sort of combination of things ignited, which I didn't know what it meant, but basically this idea of social justice and how important that is. So I didn't have a name for it, but that is what kind of led me into thinking about these things. Because, when you just come out of medical school, you basically like an educated barbarian. You know nothing about anything except medicine. It's not like in the US or other places where you study undergrad in philosophy or English or whatever it might be to give you a kind of a broader sense of the world. You immediately start with biomedical sciences, and there's very little exposure to any of social sciences or public health. And it's very difficult for you to really understand how these broader socioeconomic issues impact you and your practice, as well as, the kind of patients that you see and their outcomes. In any case, at that time, my brother was studying politics, philosophy, and economics at UCT. And, obviously I speak to my brother. So, so he he influenced my thinking as well. And I became sort of more interested in particularly economics and political philosophy, and especially Marxism. So I became quite a socialist at that time, and I decided, look, I'm not doing this medicine thing. I can't do it. Like it's I feel like I'm in the trenches and I'm just not getting anywhere. And it's exhausting, and I want to make a difference sort of on a higher level. So I left clinical medicine. I went to UCT and I studied politics, economics, and philosophy for like a year and a half or so. And by the end of that, I had a very strong sense of what my sort of political and social views were, which is, at heart, I'm a Rawlsian, and I believe in liberal egalitarianism. And that's the kind of the worldview that I still hold today. So my friend was busy. He was applying for public health medicine job at Stellenbosch. I met with Prof. Leslie London. I sent in my application to go study at UCT, but somehow my application got lost. But I'd also sent an application to WITS. And I flew out from Cape Town, did an interview, and my post was funded through the NHLS. And I was based at the National Institute for Occupational Health in Braamfontein. And I started public health in 2011, February 1st, 2011. And at that time, my wife was my girlfriend. So she moved up with me to Cape Town. We from Cape Town to Johannesburg. And then I started my public health journey, essentially.
Okay, awesome. So yeah, that's a very, it's not an uncommon start to public health. I think a lot of the colleagues that I've been speaking to have articulated exactly the same frustration with working in the services that led them to just question more around the broader determinants or the broader structures around health. And as you articulated, getting angry and burnt out and just feeling like you were swimming upstream. So I think that is that's quite a common journey. I do like what you said about life being a series of uninformed decisions, and I think that's important for anyone that is watching, because sometimes it feels like younger colleagues feel that they need to, or there's this pressure to specialize, especially since there's not a lot of training posts, so people feel that they need to get into a post somewhere, and may just decide on something because of this pressure. So I think it's also good just to articulate that while all of these career conversations do look like everyone followed a really nice journey, and everything converged to one point, at the time we were all just doing the best with the information that we had at the moment. So
yes.
I think that's a really great reflection. So after that, you specialized in adverts, and then what did you do after your specialization, and then how did you come to transition back into clinical medicine?
So, my initial start at in public health, I think my first sort of couple of months, maybe even weeks, my primary kind of goal was to understand really what the program is about. Okay, because it's not really possible in an interview, blah blah blah, and looking at the website to get a good understanding of that. So that was the one component, and then the second component was to understand what it is that we actually end up doing. Okay. Which is the question that, these are the kind of questions that we're still asking today. And it's the same questions I think Mary Kawanga and her group asked, and before that even. So this has been like, a constant sort of within the public health medicine discourse. So basically, I felt that, most of the academic rigor that I got from the program was by attending particularly MSc and biostatistics lectures. I feel in general that the public health training gave you a understanding of how to navigate a healthcare system. So I think the main advantage of doing public health medicine is that you are seated within services at different levels, whether it's at a hospital level or a national level or even with the WHO. And I had an opportunity to work across those ranges to really understand how to interact with people with different backgrounds, different nationalities even, different perspective, different incentive structures, and how to communicate with them and get your message across, and then in some way, impact on population health. And I think that's the main thing that it gave me. My frustration, I think, came in with the fact that another thing I kind of noticed with public health is that you've got your academics, and then you've got your sort of the practical guys that do stuff, and they more politically inclined, the guys that actually can be on the ground and do stuff. And I am personally more a technocrat than a politician, and I'm not very good at navigating politics. And in South Africa, as you know, navigating a political system is complicated, whether you going to Ekurhuleni and going into an informal settlement to, try and do, like, I remember I did like a measles immunization campaign, and I was like, immunizing people out of the boot of my car, whether you're doing that and trying to organize something like that, or whether you're in a boardroom, discussing an NHI policy, you really need to know how to interact with people. Otherwise, you're going to get nowhere. So that was the one part. Then the other part was, I didn't, because I was more interested sort of in the technical skills, I needed to find a way to develop those. So that's why I really focused on epidemiology and biostatistics as much as I can. And, I focused on doing research. So I did a lot of research stuff during my registrar time. Eventually I did a MSc in health economics at the LSE because I wanted to really strengthen my quantitative skills. And part of the reason that drove me to do that was because I didn't have a clear sense of where I was going to work when I was done. So, I mean, broadly, you can either work, in private sector, you can work for NGOs, or you can work for the state. So, I mean, I'd sent my CV out, sort of to Discovery, etc., but, didn't really get much traction there. I was looking at Aurum and chatting with them, but there's not that much. It wasn't clear to me where I was going to work, so I was trying to get quantitative skills to make myself more marketable. And I decided to go to the LSE because potentially I could work overseas. And then the other component was that even if I did get a job, I was worried about job security, because I think if there's any sort of budgetary issues, I think people who are not delivering services at the coal face may be the first ones to get axed sort of in a public sector setting as well as in a private sector setting. And then the final thing was just I didn't get a good sense of what the earning potentials are. So relative to other medical specializations, I was concerned about that. So then the other kind of things that drove me to, where I am now was that I did a paper on corruption with Letitia and Sharon Fon. And, I was interviewing people at different levels of the healthcare system about corruption, how it actually impacts patient outcomes. And I remember standing in an elevator with a very senior government public health official, and they told me that, if you do this kind of work, you're never going to get anywhere in public health. So, I was like, okay, I felt disillusioned, by the end of it. And I felt that, even though you're trying to do all this work, firstly, it's very hard to get it done. Secondly, it's very difficult to get your message across and get people's buy-in. And finally, it's very hard to actually assess the impact of anything that I do. And another saying that I came across, which I think is kind of pertinent, is this, you have the sense that everybody's trying to save the world, but nobody can agree on how. And that's how I felt like public health was like. It's everybody's kind of wanting the same thing, but pulling in a different direction. And I mean, the NHI bill is a classic example of that. Like everybody agrees that something needs to be done, but nobody can agree on how. So I found all of that pretty frustrating. And then I also had this nagging feeling that, I'm losing my clinical skill, and I'd been working very, very hard. Okay, well, during medical school and internship, I considered that hard work, to gain, this medical skill. And at the moment, I'm not using any of it. Like none of the work that I was doing, like really drew on any of my clinical skills. I mean, when you're at the NICD, you do work, with some clinical aspects maybe, but we're not microbiologists. Like I'm never going to have the insights in managing a outbreak that, I don't know if Juno is still there and Lucille has, so I'm not going to ever reach that level of expertise. Similarly, people who are running big randomized controlled trials that are answering important questions, I don't have the skill set to do that. A lot of the people who do a lot of public health work on a global scale are not necessarily public health trained. They may be doctors with an advanced degree in biostatistics, and they do burden of disease stuff. I can't compete with that because I don't have that kind of training. And after doing the LSE, I mean, I developed amazing skills by doing that. But even then, in the end, I'd end up working for a pharmaceutical company, probably in Europe, doing market access stuff. And I don't think that would make me that happy. And it would also not really draw on my medical skill. So all that stuff put together, I decided, okay, so I have two options. So either I can stay on this course and see where it takes me with all of this uncertainty that I've unleashed upon myself, or I can say, look, I'm not prepared to take the risk, and I'm going to make a very difficult decision, and I'm going to go back to clinical medicine after like not doing any clinical work for 6 years, and hope for the best. So that's what I ended up doing. I left. I mean, I needed to get myself out of the NHLS contract, and I started working as an emergency medicine person, in some of the emergency rooms in Joburg, and then I ended up doing anesthetics. So
interesting. So that's a lot. There's a few things that I have to pick up on this, and I think you've made some very valid points, I think, for anyone who is considering the journey. The first is around where we are placed in the health system. And as you say, that has been a continuous conversation. A lot of the time, the default is either in the services. A lot of the posts that we get are for medical management, and that may not necessarily be everyone's cup of tea. Or as you say, it's in, working at the universities in research. But if you want to kind of be a practical person doing practical work, but not involved in the politics of it, there isn't really a space. And I mean, that's partly why I ended up in consulting, because I feel like I can do some of that technocratic type work without getting steeped too much in the politics. To be fair, though, no matter who you consult for, you will be, because
politics.
You're in politics. That's what public health is.
Absolutely.
And as you say, there's a lot of it is stakeholder management. I was laughing with a colleague yesterday. I was like, we spend a lot of time just managing personalities and,
yes.
Which stakeholder wants what. And as you say, ironically, as we are having this discussion, the NHI bill is being signed in.
I've been reading the news.
Yeah, so currently is, but I'm sure by the time we're done, it would have been signed.
And I heard all the comments and suggestions were taken seriously and incorporated into the bill to ensure its successful implementation.
Yeah, so I have to
quite
say,
refreshing.
So it's just as an aside, it's quite sad from a technocratic point of view that the timing of this makes it sound be perceived more as a political what do you call it, intervention rather than something that the country
But-
actually needs to.
But on that point, I mean, healthcare is a political issue anywhere in the world. It's a political issue. It's a Marxist superstructure, the healthcare system. And if you work in that space, whether you want to believe it or not, you are part of it. And you would need to learn how to navigate that. Whether you're a clinician or whether you're a public health physician, it doesn't matter. You need to be able to navigate that system. So that's the reality.
Yes, no, that's completely correct. I think the point is that, you know, it's sad that it was used as an electioneering tool and not as articulated as something that the country is striving for in terms of universal health coverage. But anyways, that's an aside.
Side point is.
Side point. That's been a very interesting journey in terms of you know, the transition to back to clinical medicine, and really some of the factors that led you to this decision. I do want to say though, and you brought up a very valid point around like and which nobody has really spoken about yet, around earning potential. And it is, you know, a lot of the times it's easier for other clinical specialties to compare themselves to maybe, for example, the private sector and get a sense of what specialists are earning. There aren't public health specialists, medicine specialists working in the private sector. So a lot of the earning potential is pegged to what government public health or public sector specialists would get. And I know one of, you know, our colleagues said, look, you do public health for the passion, you're not expecting to get to get rich. So, you know, that's not to say that you can't go work in the private sector and earn a higher salary. But I think for a lot of people, that's not the motivating factor. I think many people come into it with the understanding that it's not a private sector specialty.
No, sure. And I mean, I didn't go into public health or left public health because of money, but you have to be practical about things as well. And it doesn't make sense to spend, you know, it's expensive to study medicine. It's expensive there's a lot of opportunity cost to doing a 4-year registrar program. And it doesn't make sense to spend, you know, 10, 15 years at university and then struggle to find a job that pays you a decent salary. So, you know, so that's, I mean, I think it's something that you should consider. Of course, whatever you do, you have to be happy doing it, right? I'm happy doing anesthetics. I'm happier doing anesthetics than I was doing public health. And the money is a separate issue, but you know, we're adults and we have to think about these things, right? You have a family, you have to, you know, provide for them, you have to provide for yourself. So, you know, I think it's a justifiable point to consider.
Yeah, and I think it's not spoken about enough, and it's something that people need to be aware of if they are making career decisions around it. Not to say you will earn at the level of a specialist, but it would be at a public sector specialist level. Obviously, you know, managers, etc., or if there's sometimes you can do overtime, etc. Those are all factors that come into it. But yeah, if you think that you may be earning at private sector levels, then you may need to adjust those expectations and make your decisions. As you say, it's not a one size fits all. It's all of these factors that somebody needs to take into account. So having said that, do you find, I mean, currently in your work, it seems like you are doing quite a clinical sort of, your day is filled with clinical work, but you are at a university. Are you doing anything that sort of overlaps between clinical work and public health?
So all my work outside giving anesthesia is public health.
Okay.
And I think public health is ubiquitous, and a lot of clinicians do public health without realizing that what they're doing is public health. So, I mean, during my I'm saying residency because that's what they call it, yeah. During my registrar time at Wits in anesthetics, you know, I did I looked at the burden of disease of C. diff in South Africa. as my embed project. So I mean that's pretty much public health, and I was involved with a bunch of sort of or theatre efficiency things during my registrar time at Wits. And then when I came to Canada, I did a fellowship in quality improvement and patient safety at Mount Sinai Hospital in Toronto. And there again, like I looked at how to implement a quality improvement program, how to make it sustainable. And now at the moment, I'm involved with research looking at access to surgical care in Ontario in Canada, particularly like the social determinants of access to surgical care in Ontario. So that was a paper that we just published, and sort of my day-to-day projects. We're working on a way to do dynamic risk assessment for cardiac surgery patients. So we're developing like AI models to predict patient outcomes in real time with electronic patient records. I'm developing like a patient care pathway for cardiac surgery patients in the hospital to kind of optimize them preoperatively, but also ensure that they have enhanced recovery after their surgery to get them out of hospital as soon as possible. So all these things draw on public health skills, because you have to understand the framework of social determinants of health. You have to understand the framework of running a quality improvement project. You have to understand the frameworks of how hospital systems work and how to do stakeholder engagement, how to get people to buy into ideas, how to do a process mapping, how to do an audit. Like all these things are public health skills, which is something that you will not, I believe, get through an MPH. It's something that you will get through doing public health medicine residency or registrar time, because that's what you do there. MPH is more didactic kind of learning, at least when I was at Wits, which is good. Like you need those skills, but learning something on a PowerPoint slide and going to a Kureleni and actually doing it are two vastly different things. And it's only by doing public health medicine that you would really, I think, gain the skills to be able to do that. So yes, I don't regret doing public health or anything that I've done. I think each thing has, contributed to, the way that I see the world and the way I understand, the way I interact with people. I think it's made me a more rounded individual, a more rounded clinician. I have a better sense of all the factors that may play into a certain clinical scenario. And it's given me a skill set to, make a difference on, even though it's a smaller population, but the population of patients that I look after on a daily basis. And also I can see the impact of my public health, projects more instantaneously. I mean, it's not as instantaneous as giving somebody propofol and watching them go to sleep, but I can, develop interventions and actually monitor them and see how they actually impact on patient care. So all these things are immensely gratifying. And a lot of it, is because of my public health sort of training.
Thanks for that. I think that's gives a really great insight into how you can utilize your public health skills, even if you are, back in clinical medicine, because I think that the point that you make around the MPH and the MMed is valid, in that the MPH, I did an MPH and then I went into my reg time. And what a lot of people do struggle to do is to translate what you learn in an MPH into practical skills, which is what the MMed actually gives you, because you are steeped in the services. However, I will say that for anyone who is peripherally curious about public health and not wanting to take that leap into public health or to leave clinical medicine completely, doing some of these, diplomas or an MPH or online course does at least give you some insight to be able to articulate what you're saying. So maybe then that gives you the language, if you are, for example, working as you are, in the clinical services and want to do something around patient outcomes, it gives you the language or the methodology to be able to do that. It may be a bit of trial and error, which is what happens in our rich time.
Anyway, yeah.
Yeah. But it is an avenue for anyone that feels that they can't make the leap, or they're just curious about exactly what public health entails. And as you say, it's not and I think partly the rationale behind a lot of people going into public health, as we said in the beginning, is that they are curious about the world around clinical medicine that shapes the health system. And so doing any sort of public health training or degree only augments that. You don't, as you say, you don't regret it, because it actually just makes you more well-rounded as you approach health in the wider context. So I think that it was good to hear how you've managed to marry that, and I think it will give some of the younger colleagues at least some ideas about it doesn't have to be either or. You can find a way to
and doing a master's degree, whether it's an MSc in epidemiology or economics or MPH, that always gives you an edge, regardless of if you know what you do. If you end up being a trauma surgeon, you still have that behind your name, and you're more likely to get a reg post, and you're more likely, to progress in your career because you've got an additional qualification. And if you end up wanting to do public health, again, it gives you an edge over other applicants, right? Because it's going to give you additional points when you apply for a registrar post. So,
okay, great. So my last question is really around, and I know you started off with it about life being a series of uninformed decisions. But I'm just wondering, if you were, talking to someone who's contemplating public health or trying to figure out, where their place is in health, whether it's in clinical medicine or in public health, any specific advice that you have for someone?
I think my advice would be to decide if you are a clinician or not. Because, and I think for some people, it's a very easy decision. They love clinical medicine and there's no two doubts about it. Other people are like, I actually really don't like clinical medicine. I'd rather do an MBA or whatever and go and, do non-clinical stuff. But if you like clinical medicine, even if you're disillusioned by it, if you then decide to go and do public health, you're not going to be able to do clinical medicine as well. Like in my mind, because I really tried to do clinical stuff when I was a registrar, and it's just not feasible unless you do something very, very specific, like maybe HIV clinic or something like that. But I think that you have to be willing to forego really being steeped in clinical medicine if you do public health. Of course, you can be a clinician and still do public health stuff, but I think the reverse is less true. And the reason for that is just simply that, you've got, medicine in general, a lot of it, it's become highly specialized, and at least where I'm working, and you need to really be up to date with the most recent stuff, and it's a constant thing that you have to work on. It's not something like clinical medicine. It's not something you can dabble with. It's something that you do on a day-to-day basis. So that's kind of my opinion on it. Having said that, like let's say theoretically, if I went back to 2011 and instead of going to do public health, I did anesthesiology straight off the bat, I would never have had the same appreciation for clinical medicine that I do now. For me as an individual and as just my personal kind of journey, I was very disillusioned with medicine. Maybe it was just because I was still young and what have you, and I didn't know what I was doing. But I needed to lose it in order to really appreciate it again. So public health gave me two things. It gave me a very deep appreciation for clinical medicine, and then it also gave me, all these other things that we've spoken about, how it's rounded me as an individual and a clinician. So for me, it was the right path. I don't have a different option because I can't reverse time, but I'm happy with the way that things worked out, and I'm very happy with what I'm doing now. So.
Thanks, Peter. So I think it's an important point around deciding whether or not you are a clinician. I think for two reasons. One is, I just want to point out to anyone watching, is that public health is not the default if you don't like to see patients. There's many other things you can do. It is also still quite technical. You have to enjoy it. You have to have a passion for it. But it is important to know, because if you are really interested in clinical medicine, as you say, there isn't much opportunity. Yes, there are people who do overtime in the, like in casualty or whatever, but it's not, they're not pursuing, it's more sort of keeping your skills up to date, and they're not really pursuing a clinical medicine track going into pediatrics, etc., as you say. And similarly for, you can't do public health. By the way, as well, you also have to be keeping up with methodology, etc. So you have to really, I think that's a really good point about having to really decide where your main focus is, and then maybe augmenting it. So yes, you could still be a public health physician and go work. Actually, no, we can't, because once you're a specialist, then we're very constrained in what type of clinical work we can do. But it's not, you can't then go and be go and do an anesthetics unless you are trained in anesthetics again. So that is an important decision for people to make, to figure out where they lie in that spectrum of clinical versus more, managerial or public health, population health focused. So yeah, I think for many people, as you say, it's a disillusionment with clinical medicine. But sometimes a break and doing something else does allow you to see the value of the clinical skills, or how much you actually enjoyed clinical medicine in the first place. And it was maybe extenuating circumstances, especially after like 2 years of internship in community service. You're like so tired of the system.
No, you are.
Disillusioned. And I think for a lot of the people who are watching at the moment, I'm sure you know this, we have issues with frozen posts and junior doctors not being employed. And that is, although that is something, which would factor in, don't let that be the reason why you decide to pursue public health, because you're scared that you're not going to get a job in clinical medicine. If clinical medicine is for you, then you should be trying as best as you can to pursue that path. All right, Peter. So thank you. This has been a really interesting conversation. I think it will definitely give those watching some more insight into this sort of tension, or sort of weighing up between clinical medicine and public health, and ways that you can bring them together if you so wish to do so. Before we close, any last reflections or words from you?
No, not that I can think of. I mean, I think I've said my piece.
Great. Well, thank you so much for your time. Really appreciate you taking the time out to have this discussion with me. And like I said, I'm quite sure that someone watching out there who is grappling with similar issues will at least have a clearer idea of some of the considerations that fit into your decision making, and use them hopefully to chart a path forward.
Okay, awesome.
Thank you so much.
Thanks,
Have a lovely day.